Hello, and welcome to Advancements in Bladder Cancer as it relates to the Advancements in Urology and AUA-JUA Symposium. The AUA strives to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this enduring material for a maximum of 1 AMA PRA Category 1 credits. Course evaluations and CME credit will be administered electronically on AUA University immediately after the course. Evaluations are very important, read carefully by faculty members, and are used for our ongoing needs assessment in selecting core subjects and faculty for future meetings. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format of this program. All persons in a position to control the content of an AUA educational activity are required to disclose to the provider all financial relationships with any commercial interest. Please visit AUA University to view Faculty, Education Council, and COI workgroup disclosures. The AUA would like to thank Astellas and Pfizer, Inc., Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and Merck & Co., Inc., for providing independent educational grants in support of this activity. You are prohibited from using or uploading content you access through this activity into external applications, bots, software, or websites, including those using artificial intelligence, technologies, and infrastructure, including deep learning, machine learning, and large language models and generative AI. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Finally, I would like to introduce and extend a special thank you to our course director and moderator, Dr. Kristen Scarpato, for her time, talent, and expertise in developing this program. Dr. Scarpato is an associate professor of urology at Vanderbilt University Medical Center, where she completed a fellowship in urologic oncology. She is the program director for the urology residency and the vice chair of education for the Department of Urology. Her clinical and research interests focus on the diagnosis and management of prostate and bladder cancers. She's dedicated to improving medical education and mentoring trainees. I will now turn the course over to Dr. Scarpato.
Thank you, and welcome everyone. I'm really excited to be here as a part of this AUA-JUA collaboration. We will be completing 3 separate sessions related to urologic oncology, and I am hopeful that you learn a lot from this bladder cancer session. We're going to talk about risk stratification for patients with non-muscle invasive bladder cancer. Then we'll go through the available treatments for patients who have BCG unresponsive non-muscle invasive bladder cancer. And then finally, we'll finish up with some guideline-based management discussions surrounding patients who have non-metastatic muscle invasive bladder cancer. I am so pleased to welcome my colleagues today who will be serving as course faculty. Very cool that we are collaborating kind of across the globe right now. I'm in Nashville, Tennessee. I first want to introduce my friend and colleague, Dr. Sima Porten, who is Associate Professor of Urology at UCSF, and she is a bladder cancer expert, well known for her great work in this space. So she will be joining us on behalf of the AUA. And then all the way from Tsukuba, Japan, my new friend and colleague, Dr. Nishiyama, who serves as the chairman of the Urological Cancer Group in Japan Clinical Oncology Group. So thank you both for joining us today. I know we'll have a great discussion on bladder cancer. All right, well, let's get right to it. In our first segment, we're going to focus on risk stratification for non-muscle invasive bladder cancer. And I always like to kind of start off with the basics. What are the important variables? Why do we care about risk stratification? And importantly, how do we risk stratify? So I'll start first by asking Dr. Nishiyama about important factors both for the AUA as well as the JUA regarding risk stratification for patients with non-muscle invasive bladder cancer.
Okay, thank you very much, Scarpato. So my name is Hiroyuki Nishiyama from Japan, JUA side. So please show my slide number 4. Yeah. So this classification is quite important to decide the decision making or how to treat the non-muscle invasive bladder cancer. And risk has two meanings. One is a progression risk, and another is a recurrence risk. So here is I show the JUA risk classification. In JUA is we stratify the 3 risks. One is a low risk, second is an intermediate, third is a high risk. However, recently we follow the EAU guideline and we put in the highest risk groups. So low risk is a TA low grade and less than 3 centimeter with a single tumor. And high risk is a T1 or high grade or CIS. However, definitely intermediate is in the middle risk. And highest risk is a T1 high grade, and sometimes it's concomitant with CIS or bigger 3 centimeter or variant histology or BCG unresponsive. So highest risk is we recommend immediate cystectomy, but we need to discussion. And also AUA guideline recommend some risk classification, but almost same parameter. And another important factor is the depth of the invasion in the T1 disease or how frequently it's a recurrence. Such a parameter also important for decide the risk classification. So this is my talk. So
Great, thank you. And that is, as you highlighted, very similar to the AUA risk stratification system where we're looking at tumor grade, depth of invasion, size of the tumor, presence of CIS, multifocality is important, and things like variant histology. Dr. Porten, do you agree? Similar to risk stratification for AUA?
Yes, very similar, although I think the high-risk group is kind of bundled together and not distributed out as the JUA guidelines, like was highlighted, is aligned with the newest version of the EAU guidelines.
Yes, okay. And any biomarkers that you're using as a part of risk stratification at this point? First, I'll ask you, Dr. Porten, and then.
Yeah, currently I'm not using any biomarkers for risk stratification. Right now at this time, the majority of our biomarkers in this space are under investigation versus in sort of routine clinical practice. There are some molecular classifiers that are available, primarily that offered by Decipher or Veracyte, that can take high-grade T1 patients and help you maybe from a molecular basis kind of determine if you feel like this is a more aggressive disease. So those classifiers don't really help you right now in terms of predicting like what happens in the future with your current treatments, but the one classifier available can help you figure out, hey, am I understaging someone at this time, or am I at risk of understaging somebody?
Great. And Dr. Nishiyama, beyond urine cytology, are you using any biomarkers for risk stratification yet?
Yeah, in Japan, it's the same situation. But recently, honestly, I'm using the cytology, and also Eurovision is available in Japan. But we use the cytology very frequently, but the Eurovision is quite expensive, so not common using. But I think it has some meaning to predictive the recurrence.
Yeah, and I think it makes so much sense that urinary biomarkers would be useful for risk stratification, screening, follow-up, response to therapy, but we're just not quite there yet. So I'm hopeful that in the near future we have some very reliable biomarkers for our use. There are other tools available for risk stratification that are commonly referred to and maybe not always appropriate for kind of current day patients. But Dr. Porten, can you talk to us about the EORTC risk stratification and the Spanish tables?
Sure. The EORTC risk stratification calculator was based on combined data from 7 trials. I think there it's important to note that these were very large trials based on many, many patients, but those patients didn't necessarily have a high rate of BCG therapy or adequate BCG therapy or even perioperative chemotherapy. But I still think they're very valuable as they use factors such as tumor size, number of tumors, grade, stage, presence of CIS, and the prior recurrence rate. And that brings in what was discussed in terms of that time factor that I think is important. And it can give you a number, a percentage number of your risk of recurrence and risk of progression. And I think that's a great place to start in your conversation with a patient about what you think might be the best treatment option for them in terms of trying to discuss with them, this is what the natural history is, this is what I expect, and perhaps these are different ways to mitigate that recurrence rate and that progression rate. And that could be a variety of our intravesical therapies or considering an early radical cystectomy. So I think they still provide a lot of value, even though perhaps they may overestimate risk when we kind of look at more contemporary data. And same with the Spanish tables as well. I think that all of those have some shortcomings, but still in this day and age, a tremendous value in talking with patients. Dr. Rich over at University of Miami put together a really nice website or calculator. It's like Bladder TUR or BLATUR.com. It's really easy to use, and it kind of walks you through like guideline-based recommendations and then sort of treatments and helps you estimate if somebody is low, intermediate, or high risk, and perhaps will guide you to consider a few of the AUA guideline endorsed recommendations like periop chemotherapy, BCG maintenance, etc. So I think it's a really nice way for trainees, especially to get familiar with this language.
I agree. And one of my favorite things about Dr. Rich's risk calculator is that it will link in clinical trials. So you can see what's available for a patient who fits into that kind of risk stratification or disease space. And it is really cool. I encourage everyone to check it out. So you both have highlighted the importance of recurrence and progression. So risk stratification allows us to appropriately counsel our patients about both of those risks. So Dr. Nishiyama, I'm hopeful that you can tell us kind of how you counsel your patients about the risk of progression by their risk group.
Okay, thank you very much. So please show the next slide. So this is a JUA guideline recommend to the flow chart. It's quite simple. I know the AUA guideline, but it's more complicated. So honestly, if patient is a low risk, then I recommend single instillation after QRBT immediately. And also intermediate risk. It's a very, very controversial. So in Japan, the half of urologists using the BCG instillation for intermediate risk, but another half recommend the intravesical chemotherapy with maintenance. It's a big controversial. If patient is high risk, then definitely I recommend the BCG instillation. But in Japan, half of urologists using a BCG with maintenance, and another half is a BCG induction alone. And if patient is recurred, then we try the second course BCG. So that's a treatment option is two different. But if patient is the highest risk is honestly immediate cystectomy is one option. And also we recommend T1 disease, then secondary TUR is mandatory. So that's our strategy.
Yeah, that is very similar, I think, to what we are doing. And I want to highlight your comment about intermediate risk patients. They really are, it's a heterogeneous group. And so we also had some discussion and controversy about how to best manage those patients. Is it BCG? Is it, observation? Is it chemotherapy? If we're using induction, are we also using maintenance, and how much? And I think there's a lot of activity in the intermediate risk stratification group now, and I look forward to seeing where we kind of land with that. But certainly the highest risk patients are the ones that we talk about earlier, timely cystectomy. And I think this is a good point to transition and talk about variant histologies and how we handle those in our practice. So Dr. Porten, can you talk to us about variant histologies?
Yeah, they're more rare in non-muscle invasive bladder cancer than muscle invasive bladder cancer, so you don't see them as often. In particular, variant histologies like small cell, plasmacytoid, sarcomatoid, and micropapillary. I think here, Dr. Nishiyama brought up the importance of a re-TUR for high-grade T1. I think that can be expanded to a variant histology as well, whether it's a TA or a T1. Anytime you see your pathologist comment on that, you should be very suspicious that you have been understaging the patient. And so I think that it's recognizing this is a rare disease entity. You should get a secondary GU pathology review and then consider augmenting your staging for that patient with a re-TUR and imaging.
Great. And the importance of having a skilled GU pathologist can't be, overstated. I think, is there more variant histology now, or are we just able to identify it better based on training? I don't know, but I love our GU pathologists here, and they are incredibly good and collegial in that if there is something that warrants a second opinion, we talk about it kind of as a group and have a robust tumor board, because these patients can be challenging. If it truly is a non-muscle invasive variant histology, are you giving them intravesical therapy, or are you moving to cystectomy? And I think we're kind of learning a little bit more about how to best manage these patients, but it can be challenging for sure. Are you seeing much variant histology in Japan?
Yeah, so in Japan, we're discussing the 2 points. One is T1 disease is sometimes a micropapillary variant is included. But if micropapillary is a high volume, then definitely we recommend a cystectomy. But sometimes that's very, very huge micropapillary component in T1. At the time is a pathological report, including the micropapillary. Then such time that some urologists recommend a cystectomy, but some urologists is a very, very huge component. So I think that information is quite important to the using the variant histology information. And also T1 disease, another NMIBC is a variant history is a very, very small information. Yeah, so for example, adenocarcinoma or squamous metaplasia, it's such a differentiation is a not so big impact on the recurrence or progression. Yeah.
Absolutely. I especially worry about the progression in those patients. So I want to finish. Sorry, go ahead, sir.
Oh, yeah. And also another important is sometimes when we're using the intravesical chemo or intravesical BCG, at the time the discussion point is that recurrence is important for endpoint or progression is important for endpoint. So BCG maintenance is definitely reduce the recurrence, but progression is maybe it's the same to BCG with maintenance versus BCG and secondary BCG. So that's a discussion point.
Thank you. Appreciate that. So closing on risk stratification, it's important for managing your patients in terms of what treatments are available and counseling them on their risk of recurrence and progression. And I want to just remind everyone that when there is a recurrence, the clock resets. So we go back to our risk stratification factors and we re-stratify patients. So it is not something that is one and done. As our patient disease kind of evolves, we have to remember to re-stratify our patients with each recurrence. So why don't we segue now into our second topic, since we're talking about high-risk non-muscle invasive patients. Let's talk about BCG unresponsive bladder cancer. I think there are many terminologies that are utilized in this space that can be somewhat confusing and can have some overlap. And so I'm hopeful, Dr. Nishiyama, that you can take us through some of these words that are used to describe patients with BCG disease that may not be responsive.
Okay, please show my slide table 3. Yeah. So in Japan, I make this table in 2020. At the time, we're using some terminology. It's a BCG failure, BCG refractory, BCG relapsing, and also we decided BCG unresponsive. And another terminology is BCG intolerant. And also important is what's an adequate BCG. So that terminology is quite important. Recently, we also using the BCG experience. So that's the terminology is following the clinical trial. So many international clinical trials design the target BCG unresponsive or BCG naive or BCG experience. So important is that terminology. And how different is that terminology? So BCG failure is genetically all cases recurrence case after BCG intravesical. BCG refractory is important that's at 3 months after adequate BCG or but do not disappear at 6 months. BCG relapsing is more slower. So early relapsing is less than after 3 months, but less than 12 months. If patient is recurred after 12 months before the 24 months, so that's we call the BCG relapsing. And recently, more important terminology is BCG unresponsive. BCG unresponsive is including the BCG early relapsing and also BCG refractory. So that's a clinically important to target to the develop the new drug or clinical trial. That's all. Thank you very much.
Great. I just had one question about that. Were you saying that there is a new group that you recognize BCG experienced, meaning they've had some BCG before?
So BCG experience is they including the because the important is the adequate BCG. So this table is adequate BCG is induction with more than 2 cycle or BCG or 2 course BCG. So definitely we should say what's an adequate BCG. It's definitely BCG maintenance or not. However, in Japan, the half of urologists using the BCG induction alone. At the time, is only 6 times in intravesical installation, and they recurred. At the time, we call that patient is a BCG experience. So BCG experience and BCG unresponsive is different. It's based on the what adequate BCG or just BCG induction alone. So that's a different terminology.
Okay, thank you. That was helpful. So kind of building on that and maybe reiterating some of what you have said, Dr. Porten, can you talk to us about BCG unresponsive and kind of the FDA definitions of BCG unresponsive and then adequate BCG?
Yeah, so this came from a need to have more specific terminology to find a group of patients that don't benefit from more BCG. And so that definition was created so that there would be a pathway or space for single arm trials to sort of provide treatment options available to our patients when the kind of gold standard is radical cystectomy, which either is something that patients don't want to do or they can't. And so that's where that this definition kind of came about. And it really is, there's many different ways to say it, but my residents and fellows say that this is the easiest for them to understand. So it's persistent or new T1 high-grade disease at first evaluation, meaning at that first cysto following induction BCG, if you have high-grade T1 disease, you're BCG unresponsive. Then the next group of patients are those with persistent or recurrent CIS within 12 months of completing adequate BCG, and I'll talk about what adequate BCG is. So that captures a group of patients that say they started with CIS, they can have induction, they might still have a positive cytology, maybe a little CIS. You can reinduce them and continue to follow, or it can be an induction plus a maintenance. It makes space for those patients with persistent or recurrent carcinoma in situ. And in that category, you really do have to have enough adequate BCG. Adequate BCG is at least 5 of 6 doses of induction and at least 2 additional doses of maintenance. And the last group of patients with BCG unresponsive disease is those with recurrent high-grade TA or T1 within 6 months of completing adequate BCG therapy. And so this kind of identifies a group of patients you wouldn't give more BCG to who wouldn't benefit from that. This BCG experience or BCG exposed terminology has kind of come about because life is messy. Not every patient fits into this BCG unresponsive box, right? And it's actually, it can be challenging to find like the exact BCG unresponsive patient for some of our clinical trials. And so what's sort of come about is maybe something a little more real world, which is these BCG experienced or exposed. Those are patients that may benefit from more BCG, but for various reasons, whether it's practice patterns or shortages or side effects or who knows, pretty much anything that can happen in life, it allows at least a classification within which to design and risk stratify trials for.
Great. That was super helpful. Thank you. I think, you know, to your point, for a long time, guidelines would recommend BCG or cystectomy for clinical trial. There wasn't a lot for patients with high-risk disease, especially those who weren't responsive. And if they didn't qualify for a clinical trial based on their BCG experience, we're kind of in a situation where, what do we do? How can we help these patients, especially if they weren't or aren't candidates for radical cystectomy? So let's kind of talk about the history there and where we are now and where we came from for patients who aren't responsive to BCG. Like what are the FDA approved agents, and how are we using them?
Sure. Yeah, so we, like you mentioned, there was limited alternatives in the past. There was valrubicin, which was approved for BCG unresponsive carcinoma in situ, or BCG refractory carcinoma in situ at that time, based on that terminology. And uptake wasn't high because when you looked at real world outcomes, response rates were pretty small, maybe 10 or 15%. And so after having valrubicin for a long period of time, pembrolizumab was recently approved by the FDA in the treatment of BCG unresponsive carcinoma in situ, based on the early results from KEYNOTE-057, which looked at patients with carcinoma in situ plus minus papillary disease. That was the first cohort that sort of came out with their results. And what they found is by treating with an IV PD-1 inhibitor, pembrolizumab, that about 40% of patients had a CR, a complete response at 3 months. And this was done visibly and with cytology, so not biopsy proven. And of those 40% of patients, about half of them continued to have a complete response at 1 year. So when you kind of look at overall response rate, it ended up being about 19 to 20%. I think it was, although the durable response was lower than what everyone had hoped for, this really was the first kind of drop in the pond in this explosion of new treatment options for patients, right, with BCG unresponsive non-muscle invasive bladder cancer. So I think it was important from that aspect. It also showed that there might be other drug delivery systems, treatment strategies that could be used, not just intravesical therapies, although intravesical delivery is sort of the preferred option in this space. I think it opened up a whole world of possibilities for patients. I think one comment is that just recently they reported on cohort B. And so these were patients with papillary disease, high-grade TA and T1 disease. And in there, you're sort of looking at something a little different. You're not looking at the disappearance and complete response of something like carcinoma in situ going away. What you really want to look at is disease-free rate at 12 months or 24 months. And so they reported their 12-month data showing that patients with BCG unresponsive papillary disease had a 44% disease-free rate, which also is pretty good in this setting. I think some of the newer drugs may beat those benchmarks and do better, but I do think it has a role in the treatment of patients. And I think the only caveat is that what type of immune adverse events will you be able to tolerate in this situation when there are now more alternatives? And I think that's going to come into play. And then also just us as urologists being aware and recognizing these immune-related adverse events, as we tend to be the first call that patients make when they're experiencing a side effect or an issue.
Yeah, I think that's a really important point. And, it is exciting. And it really, this space, as you said, has really kind of exploded. I do worry also about the financial toxicity associated with pembrolizumab and with many of these agents, but we already know that bladder cancer is one of the most expensive cancers to manage. And when I think about systemic therapy with pembrolizumab, it is quite pricey. And so we want to be thoughtful about that as we're kind of navigating this advanced space. Are you using pembrolizumab at all in Japan?
Yeah, so that's a big issue and a discussion point because Keynote 05057 is a Japan and Europe country joined to that clinical trial. However, only USA approved the pembrolizumab for BCG unresponsive and not approved in Japan and also Europe. So that's a discussion point. It's a single arm trial. So it's not compared. At the time, the PMDA asked me or some expert of JUA urologist, it's a big surprising data or not? At the time, definitely durable response is 30%. However, such a durable response is CR rate is maybe 70 or something. So I think it's only 20% of patient is a long-term CR, and another 80% is not. So at the time is if we use only second TUR or another TUR and intravesical chemotherapy, then that data is we can't compare. So that's one reason Japan don't approve the pembrolizumab yet. And nadofaragine firanlimab, so that's intravesical adenoviral chemotherapy is now ongoing in Japan. So still in Japan that we have no way using the new drug for BCG unresponsive. So that's our big issue. So we want to know the situation in the USA. Thank you.
Yeah, thank you. Pembrolizumab, bladder cancer is kind of an immune modulated disease. We've learned that a little bit with BCG and now with pembrolizumab. And I'll just make one more point about it. It does seem that there are a number of different trials now that are incorporating pembrolizumab into the treatment, either intravesically or systemically. And so I think it does show a lot of promise. Side effects, immune adverse events, and financial toxicity kind of aside, I think it will be something that's important going forwards. And as we all know, we have to wait to see the data before we're using this broadly. But as you mentioned, natafaragine, faradovec, I don't know why they all have to have these crazy names, but another FDA-approved agent for BCG unresponsive bladder cancer. Sima, are you guys using that yet at UCSF?
We just started.
Great.
Having that as a treatment option.
Just a small quick question to Sima. So when you use the pembrolizumab for BCG unresponsive, at the time, do you recommend the BCG PD-L1 expression or compound diagnosis?
Yeah, so we get it because we're curious, but if a patient, after the shared decision-making process and kind of weighing all the options, favors a systemic immunotherapy, we don't use their PD-1, PD-L1 status to say yes or no to that.
Okay, thank you very much. So that's also important because the PD-L1 expression is not covered in Japan any stage. So that's another big issue. Thank you very much.
Great. Yeah, we just started using it at Vanderbilt as well, and it is so far going well, and logistically doesn't seem to be too different from kind of what we're familiar with for managing these patients. And it's nice to have another intravesical option for someone who's BCG unresponsive. Any other thoughts on natafaragene before we kind of transition?
I think again, when you look at durability, that's where I think we will have to see what the future holds with these different treatments. And maybe if there's enough of them that have different mechanism of action and low side effect profile, maybe we just need them to work for a bit of time. But it's going to be really interesting, and also I think important as we look at the next generation of trial design, how we incorporate that into approvals in practice. Because I think that would be great. I think the other benefit of natafaragene is the very small amount of doctor's appointments. The fact that you can give it once every 3 months, particularly for patients that travel far, and particularly for patients whose bladders have seen a lot of action, it's been really nice for them to have a treatment option that's able to minimize side effects from that aspect.
Can I ask one question? Because natafaragene is maybe we need to 100 microliter of intravesical. So in Japan, the Mainichi joined to the clinical trial. At the time, the patient is BCG unresponsive. So BCG is a little bit shrink. At the time, is very difficult to 2 hours maintenance. So do you have some comment to the how to using the such point?
In terms of managing that the volume is more,
Yeah.
right? I think right now the volume that is used or what's available is about 75 milliliters currently, so it's a little less. I think that's what it's ending up being when it's drawn up and instilled in the bladder. But we use a very similar patient education protocol about talking with them about minimizing caffeine in the morning and also fluids. So having just enough for providing a urine sample to rule out infection so they can have the treatment. We've started working with patients on those kind of aspects, trying to have as many appointments as we can during the morning time for that reason. And I think when we initiated that patient education component to our intravesical therapy bundle, it lessened the calls and improved ability for dwell time.
Okay, thank you very much.
I love that you have a patient education bundle. Is that written materials or a link to a website?
It is written materials, and we did it through our patient education committee. So it had the input of our clinic nurses, our infusion nurses, and many of our patients who had been through therapy, both men and women. So there's a lot of information on different aspects on diet and lifestyle things in terms of being able to hold your treatment in, as well as post-installation considerations such as protection for intercourse and how that might differ between the genders, etc.
That's excellent. I love that. I think patients are very savvy, especially bladder cancer patients, and part of successful management of bladder cancer patients, I think, is a huge part of it is managing expectations and letting them know what is coming and what they might expect. And I think, for example, blue light, and we might talk a little bit about CISView later, but if you don't tell the patient that they're going to need a catheter in advance so that the agent can be instilled, they're not going to be very happy, and it's going to contribute to a frustrating experience. And so with these intravesical therapies, letting them know what to expect, whether it's written materials or patient videos, which is what we've started using, I think that is excellent. I love that. Are you using patient education materials in Japan for your patients?
Not yet, because not new drug is available in the under the situation. So, but definitely in the near future, it's coming. So we follow your experience. Thank you.
Great. All right, let's talk for a minute about the BCG shortage. I know in the United States, it really had an impact that I think had some positives, some negatives. I think a lot of development actually came out of having a shortage and how we're going to manage these patients. But Dr. Porten, how has the BCG shortage impacted your practice, and particularly how you manage high-risk patients?
It's definitely been challenging because it's unpredictable when you will be in a shortage or not. We actually implemented an automatic vial counting system with our pharmacy, and then figured out when the amount goes below a certain number, that is predictive of when a shortage is coming. So we'll have to go into shortage mode, which is prioritizing patients early in their treatment, prioritizing patients with high-risk disease and CIS primarily, and probably letting go of the folks that are at the end of their maintenance therapy or putting that on pause. And so once we did that, that became a little more manageable from a system standpoint and scheduling and clinic standpoint. But it definitely has had an impact. We, it actually helped in a way in speeding up our ability to open clinical trials. So primarily SWOG 1602, which is looking at the Tokyo strain with priming or not priming compared to TICE, as well as now the bridge study, which is comparing gemcitabine and docetaxel with BCG head-to-head in a randomized fashion.
Yeah, really excited about Gem-Doce and using it up front, using it in BCG unresponsive. And I think that our clinic now has developed a very efficient system for kind of navigating patients through 2 different sequential intravesical agents. And again, like patient expectations and understanding kind of what the day will bring for them or what their therapy will bring. But the responses look really good too, and patients tend to tolerate it. So, that's kind of one of the, I would say, positive aspects to maybe come out of the shortage. Are you experiencing any sort of shortage with BCG in Japan?
Yeah, please show them my slide. So number 7. So honestly, in Japan, we have a Tokyo strain, so no problem for about the shortage. However, still we have some clinical question. So high-grade T1 disease is definitely high risk. So all countries recommend BCG maintenance. But sometimes we are second TUR, then 30% is a T0. So at the time my question is definitely we need a BCG maintenance or BCG induction, or sometimes watch and wait is enough. So we started that clinical trial from 2012, and this year key open. So maybe this is we have some answer of the how about the indication of the BCG treatment for the T1 disease, but if second TR is a T0 disease, at the time is what's the standard therapy? Yeah.
Great. All right. I think in the interest of time, as much as I want to keep talking about exciting developments in the BCG unresponsive space, let's move on now to current best practices for non-metastatic muscle invasive bladder cancer. Again, want to just kind of start with basics. So Dr. Nishiyama, can you just tell us kind of how you work up patients who come to see you for muscle invasive bladder cancer? How are you managing them, working them up, starting from kind of in the office to TURBT and your technique, and then your staging evaluation?
Okay, thank you very much. So important is that when we diagnosis of muscle invasive, at the time TUR technique is quite important because sometimes we do the TUR, then coagulation effect has impact on the pathology. So definitely, if we can do the en bloc, then pathologists more happy because easy to identify the muscle invasive. And maybe 20 or 30% is we do the good TUR. However, still we pathologists cannot identify the muscle invasive portion. Important is that we should pick up the muscle invasive layer. However, pathologists have some discussion. Sometimes true what's a muscle layer? So sometimes the subcutaneous, submucosal muscle layer and true muscle. So that's a discussion point. And another discussion point is that if pathologists identify the muscle invasive area, so we need to decide the TNM staging. At the time, nodal positive or not, then treatment strategies are completely different. So at the time is that we recommend CT and MRI. And if nodal size is more than 1 centimeter, then definitely it's a metastasis. But sometimes a 5 millimeter to 8 millimeters, that is very controversial, is a nodal positive or not. So that's another discussion point. So at the time is a MRI, or sometimes we recommend a PET, CT imaging or not. And also important is that sometimes the NMIBC is concomitant with the upper urinary tract disease. So definitely we need to check the hydronephrosis is not one yet. So that's 3 points is quite important in evaluation.
Great. Yes, you were very comprehensive there and brought up a lot of good points. One of my takeaways from what you said is keep the pathologist happy, and I totally agree with that. And if you are over-cauterizing your specimens, it will be hard for them to interpret, and it will not keep them happy. Dr. Porten, are you a monopolar or a bipolar girl?
I like using a bipolar resection technique. I mean, and I agree. I do try to go for a complete resection. I know that there's a lot of different strong feelings about, do you just need to get the muscle invasive disease and then you can move onward with whatever therapy you're going to do, or do you try to go for a complete resection? I still am a believer that TURBT is probably one of the more important oncologic procedures that we do, and it does have a potential to have an impact.
I totally agree. And it's been awesome to see a number of different publications, whether it's AUA News or medical journals, Journal of Urology, talking about the art of the TURBT. And I think there's a little bit sometimes of mislabeling TURBT as a minor endoscopic procedure, but actually to do a quality TURBT is hard, and you need to be deliberate. And I think that there are a lot of ways to optimize how you do your TURBT. And ultimately, I think it comes down to your preference and your experience in terms of which tools that you're using, but it is certainly something that requires skill and preparation. And I think it's one of my favorite procedures, and I enjoy trying to teach the trainees about how to kind of optimize their technique. So let's talk for a second about enhanced endoscopy. Are you using any narrowband imaging or any blue light in Japan?
Yeah, in Japan, not you imagine, but MRI virus is some radiation colleges recommend, but not still popular in whole Japan. So prostate is a very common virus, but virus is not common. So now we start to education how to using the like that too. And another important point is virus is quite important before TLBT. But in Japan, the TLBT is first, then MRI check. At that time, the virus is not working. So that's another big issue in Japan. Yeah.
We are kind of sparingly using MRI in bladder cancer, although I do think it certainly adds value for certain patients. And it's one of those areas where I feel personally like more to come. In the patients that is beneficial, it's super beneficial. And I've had two particular patients who have had kind of submucosal disease that wasn't obvious endoscopically, and it really helped with targeting and identifying a muscle invasive disease. What in your practice, Sima, are you using MRI for bladder at all?
I think sparingly as well for the select patient. I think if you're doing multiple lines of bladder preservation, I do think MRI can be helpful at sometimes identifying submucosal disease, whether you have done many lines of intravesical therapy or radiation therapy. I think it's also particularly helpful in evaluating female pelvic anatomy. But it is very difficult to have authorized in terms of insurance purposes. And so it is definitely limited and only accessible for those with the particular insurance.
Yeah, which is an important point. So let's bring it home now by talking about management. You have a patient who has muscle invasive bladder cancer. You mentioned trimodal therapy, Sima, so I'm going to put you on the spot. Are you using trimodal therapy, and which patients?
We are using trimodal therapy. We have a multidisciplinary bladder team that most patients get to see. It is kind of interesting, though, that the way insurance structure is set up in California, patients can see me because of the offering of radical cystectomy, and that's only done at specific centers. However, if somebody is trying to see a medical oncologist or radiation oncologist, that might have to be my wonderful colleagues in the community. So I have little groups that I work with in our local area at being able to provide these options for patients. We do select patients who have tumors that are of not too big of a size. We talk about the rate of CIS being a factor in non-muscle invasive recurrence down the road. And so we counsel patients on that, patients with hydronephrosis, and those with really like bulky disease and a lot of tumor volume. It's pretty hard to get that patient through bladder preservation or chemoradiation. But those are some of the stratification factors that we use.
Thank you. And Dr. Nishiyama, thoughts on trimodal? Yeah.
Yeah, so please show my slide number 9. So that's my final slide. So in Japan, also so please say next slide. Yeah, so in muscle invasive, so previous version is we recommend only cystectomy. So from 2019, we put in the three modality bladder preservation as an option. So importantly, who is a candidate for three modality. So I agree. So in Japan, so we decide the two population. One is elderly and frail and very difficult to cystectomy. That's one target. The other target is a patient declines healthy, but the patient don't like a cystectomy. At the time is I agree with without hydronephrosis and without less than 3 centimeter and without CIS. So that's a quite important factor. Yeah, so that's the Japanese situation.
Great. Very helpful flow chart there. One of the reasons I love oncology, flow charts. All right, in the last 2 minutes, let's just talk about systemic therapy for your non-metastatic patients. What are you using for neoadjuvant chemotherapy, Dr. Porten?
Yeah, so that's another place where I think training and practice patterns have an impact. Cisplatin-based chemotherapy is what should be used, and that can be done with Docetaxel or with gemcitabine cisplatin. And the Vesper study, I think, recently resulted and showed that Docetaxel does have a bigger impact and more of a benefit than gemcitabine and cisplatin. But I think out in practice with our different medical oncologists, really it's patient selection based on age and frailty and what they feel like a patient can tolerate, and that determines the selection of their treatment.
Yeah, absolutely. And your point about practice patterns is a good one. We're still using quite a bit of GemCis here, which is what we've been using for a while. But Docetaxel certainly has strong data behind it. But your cisplatin chemotherapy really is the important point there. Dr. Nishiyama,
Yeah.
anything to add?
In Japan, it's almost same. So many urologists using a GemCis, and because it's a very easy to. And now evidence is coming, so some urologists change the dose length and back. However, important is the dose length and back is a little bit toxic for the person. So I think it's a USA and Japan is a different situation. How many courses of neoadjuvant? So in Japan, generally two courses of GC is very popular. Okay? And some urologists using the 3 course, but I hear the USA or Europe is more than 4 cycle or more than 6 after the 6 cycle. So I think it's that courses is a little bit different situation in Japan and the USA. Yeah, but yeah.
Well, that's an interesting point. Well, I don't think we're going to get to talk, unfortunately, about best practices in radical cystectomy, but I really do want to thank you both for a great discussion on bladder cancer and kind of where we are now, what advancements we've seen recently, and highlighted some important guideline-based care for our patients using AUA and JUA. And I want to thank you both for your time and expertise. You can access the course evaluations on auanet.org/university and claim credit and a certificate. Thank you all for joining.